Heather, are we ready to begin?
We're all set to go, Representative Abercrombie.
Great. Good morning, everyone. Welcome to the Informational Forum. This is being co-hosted by Human Services, Appropriations, and Aging. I really want to take the opportunity to thank everybody for being here today, where this is a discussion about the ARPA plan for the 10% home and community-based increase. With that, I would like to ask the chairs of all the committees and rankings if they have any questions, if they have any comments. I'll start with my co-chair, Senator Moore.
Just good morning. Good to see everybody. Thank you.
Representative Case.
Oh, good morning, everybody. Nice to be here.
Senator Berthel. I don't think he's on. We will move over to appropriation. Representative Walker.
Good morning, everybody. It's great to see everybody on this bright sunny day. A little hot, but great.
Senator Austin.
Hi, good morning, everybody. I was talking with Representative Walker yesterday. I had a coat on, so she told me I was crazy. I didn't think I was because it wasn't really overly hot yesterday. It was just comfortable. And I hope everybody's having a nice day. And I have a lot of questions.
That sounds great. Representative France. I don't see him. Senator Minor. I don't see him either. Moving over to aging, apologies on behalf of Senator Miller and Representative Phelps. They weren't able to be here today, but it's Senator Kelly here, the ranking. I don't see him. And Representative Wilson.
Rep. Abercrombie, I'm here holding down the fort for aging.
Oh, great. Thank you, Representative Hughes. We appreciate it. And with that, why don't we get started? First up on our presentation is Secretary McLeod from Office of Policy and Management. Welcome, Madam.
Good morning. Good morning, Representative Abercrombie, and to our distinguished chairs, ranking and members of the Aging, Human Services, and Appropriations Subcommittee. We're very appreciative to be here with you today to jointly present the state of Connecticut's plan for investment of the home and community-based services funding that has been made available through the American Rescue Plan Act. I'm joined today by Commissioner Gifford as well as Commissioner Sheff to walk you through the details of the plan that is before you today. So we will have a joint presentation and we look forward to engaging in some Q&A as quickly as possible. I will note that Commissioner Gifford does have another meeting to attend with the governor, so she's going to participate in the beginning and hopefully rejoin. So we're going to give her an opportunity shortly to give some introductory remarks, and then her team is here to go into details in some of the DSS initiatives. So let us begin. The plan that you have before you today is a plan that strives to enhance, expand, and strengthen all of our home and community-based services. As we know, next slide, many members of the state rely on home and community-based services for basic daily living tasks, just for bathing, dressing, toileting, housekeeping, meal prep, and these are critical services that are provided throughout our state. The array of providers, next slide please, that participate in home and community-based services include home health, visiting nurses, adult daycare, homemaker and companion services, our group home providers, our residential providers, personal care assistants, and even things like Meals on Wheels types programs. I don't see the slide moving on my side, so let me pause and see if we can get that to advance.
Yeah, are others able to see the slideshow? I'm advancing it. Okay.
No, not seeing it.
Not advancing.
I can see the cover slide only, Claudio.
All right, let us try again.
Next slide.
Now,
I can see it. Yes, I can see it advancing. Does everyone else see it advancing?
Yep.
Excellent.
great,
Okay,
thank you.
perfect. So we all know that home and community-based services are critical to many different populations, individuals with intellectual or developmental disabilities, physical disabilities, and it's critical for them to be able to maintain independent living. So what did ARPA do for our home and community-based service programs? ARPA essentially provides us with what I'd call a historic opportunity to allow us to leverage a 10% federal match on qualifying home and community-based expenditures based on expenses from the time period of April 1, 2021 through March 31st, 2022. So the state will receive an additional 10% federal match. The requirements for receipt of those funds are that federal match must be reinvested in new services that support community-based long-term services and supports. Those investments must occur over a 3-year period, and that time period begins April 1st, 2021, and it runs through March 31st, 2022. Next slide. Our teams have quantified what we believe to be the estimated value of that 10% enhanced federal reimbursement. And that estimate is approximately $240 million is the additional funding that we expect to receive. As you can see here on this slide, by receiving $240 million, the use of these funds is much bigger than $240 million. Essentially, the state will be able to spend $506 million and use the $240 million as our match. So we are essentially being able to receive the 10% match, and then on those expenditures, the standard federal match that we would have received. Essentially, this is a $500 million investment plan overall, with a share of 52.6% would be the federal share and 47.4% is the state share. But the state share is essentially the funding that we've received through this 10% match. So essentially, we have a $500 million plan that is 100% funded by the feds. This is historic. It is very uncommon to see the feds allowing us to use federal dollars essentially to match federal dollars, and presents a significant opportunity for us to invest these funds in ways that will be most beneficial to the consumers and participants in our programs. As we began this process, we thought it was critically important to ensure that we were engaging key stakeholders, to ensure that their voice and input was reflected in this plan. And so I'm going to ask Commissioner Gifford and Ms. Dawn Lambert if they would talk a little bit about that stakeholder engagement process. Commissioner.
Thank you, Secretary, very much. And good morning, everyone. Thanks for the opportunity to join you, and for so many of you for joining us to talk about this important opportunity. As the Secretary said, it is highly unusual. And so we really look forward to working with you and our partners in making sure that we make the most of this opportunity to invest. The goal, I think, of Congress and the administration with this process was to really shore up the long-term strategy that you all have been closely involved in, and what we call rebalancing, or ensuring that people who are able to remain in the community that have long-term care needs have the supports that they need to. So when we learned about this, we undertook a process to make sure that we were thinking about the investments in a way that would be both sustainable, but also transformative potentially for the industry. And so our team at the Division of Health Services under Kate and now Bill's leadership with Dawn at the helm really undertook a process to talk to stakeholders and get their input. We have a longstanding rebalancing initiative steering committee that gave us input on the ARPA plan and also allowed a public comment on the plan for feedback. And you can see on the slide here the list of the organizations that participated in giving us feedback. And Dawn is quick to remind us that this wasn't something that we needed to invent quickly when Congress passed this law, that this is really the plan that you'll hear about this morning really builds on months and years of work that we have done in partnership with you and many of these stakeholders to think about if we ever had the opportunity to make further investments, what would be the most high value types of investments for the people that we serve and to shore up the provider community. So, so that was the process that was undertaken to get to the plan that you're going to see today. And I know when Commissioner Sheff speaks, he'll have additional input on the stakeholder process that they used. Madam Secretary.
Thank you, Commissioner. As we turn now to really delve into the areas of strategic investment, there are about 7 areas of focus in this plan. First, to really enhance the workforce, then to expand use of assistive technology, to expand environmental adaptations, to enhance self-direction for consumers, enhancing the delivery of services, to transform the delivery of services, to also enhance the provider infrastructure and to strengthen quality. As you look at next slide, the overall $506 million, this slide gives you a sense of where the areas of investment are and the amounts. You can see that significant funding is put into the enhancing workforce category, 37%. Claudia, you can actually go to the next slide. The types of things that are in the workforce investment category are increasing provider rates. As we know, the budget that we have before us does braid a number of funding sources to really look at the provider array and put some investments into rate increases. So a sizable portion of this category is to enhance provider rates, but also to provide some temporary stabilization to the workforce in light of coming out of COVID. So 37%, $189 million towards workforce. In the area of investing in assistive technology, this represents about 13% of the plan, $64 million. Enhancing self-direction, we've been talking for some time about utilizing electronic visit verification. These funds allow us to continue to move that initiative forward. So investments in that were very important. Expanding environmental adaptations, again, putting the resources in place to ensure that consumers or participants can actually stay in their home and using an evidence-based model that came out of Johns Hopkins, $15 million in the environmental adaptations. 10% of this plan is focused on the transforming how we deliver services, and infrastructure represents about 13%. Quality is another area of focus that you'll hear a lot about in this plan. A 20% or $100 million is to focus on funding quality improvement initiatives throughout our service array, also to make investments in our case management system, and again, to incentivize enhancing or improving quality outcomes throughout the system. And then $10 million towards evaluation and metric development to support these initiatives. I'm going to tip this to Commissioner Gifford to give her an opportunity to highlight some of the DSS components of this plan while she's able to be here with us today. And then we'll continue through the presentation. Commissioner Gifford.
Thank you, Secretary. So I would say that the investments that will come through DSS fall into three categories, as you just heard the Secretary highlight. One is assistive technology. Another is strengthening the provider network and, strengthening caregivers supports. And the third is strengthening the provider network and shoring up with rates and other payment strategies. I want the committee members to be assured that we worked really closely with our colleagues at DDS as we developed this plan. I know that in the past, it can be challenging when you have different agencies that are working on similar proposals, but with the coordination and leadership of OPM, we've really worked across agencies to develop this strategy, because we don't think about these investments strictly as DDS investments or DSS investments or DMIS investments. It's about the member. And they're meant to be centered around making sure that no matter through what agency the person is receiving their services, that these enhanced supports are available. So that's one of the principles we use. Another thing I would say with reference to the Secretary's comment about quality is that this industry, not only in Connecticut, but around the country, has not always been included, or has usually not been included, might be a better way to say it, when payers begin to think about using payment and advancing quality, even measuring quality through the payment and delivery system reform. And I know the industry is very interested in working with us on measuring quality, making sure that the investments that we're making are being translated into improvements in care for the people that we serve. And so, as the Secretary mentioned, there are investments here that will help bring this industry into the process of being able to collect data in a more systematic way, beginning to establish quality measures for the services that are provided through home care, which has really not been something that's been focused on nationally, even though we're making these very large investments. Helping them connect to other data sources so that they can know more about their patients, whether their patients are being admitted to the hospital, et cetera. So this is some of the transformative work that I alluded to earlier, which will really allow the industry to make investments in the infrastructure that we think for the long term will bring the industry more aligned with other parts of the healthcare system in terms of their ability to measure quality, report quality, and be sure that we're providing the best quality of care that we can to the people that we serve. With respect to the assistive technology, this is some really exciting opportunities, and I know Commissioner Sheff and his team will talk a little bit more about this as well. But we will be able to provide things like smart home technology for people who live in, who are served by home and community-based waivers, community first choice, MFP, or the Medicare Savings Program. These smart home technologies will be integrated into HUD 202, 236, and assisted living sites. And they will do things like allow us, for example, to identify when an individual may not have access to their cooking devices, their refrigerator or their stove. It might allow us to install a system to enhance hearing devices in subsidized housing in group areas so that people can hear better when they're participating in congregate activities. Help converting TVs into video chat, smart stoves that shut off automatically. Things like that can connect to somebody who's not in the home, but can help identify when one of the people we serve may need further assistance. So that's a really important opportunity and can enhance a person's ability to live independently and not need institutionalized care. And Dawn Lambert is here and Mike Gilbert is here. as well, who can answer your questions if you have questions about the details of those investments. On the informal caregiver side, we've really noticed that one of the things that can lead to someone needing to be institutionalized is caregiver burnout or a lack of caregiver support. And there's very good research that Dawn has shared with us that indicates that if we can just support some of these informal caregivers better and provide them with the education and respite that they might need, that sometimes that can really prevent someone who would like to remain in the home from having to be institutionalized. So we've been working with partners at the Yukon Center of Aging. There are two programs. One is called COPE and one is called Skills to Care. Both of these are to assist people, particularly caring for individuals with dementia in the community who may have very challenging behaviors. Both of these models will be able to support caregivers, provide them with the education and respite that they need to be able to continue caring for people in the community. And finally, this ARPA reinvestment really affords us the opportunity to make significant investments in rates for our providers. There's all of the HCBS waiver services will receive a one-time stabilization payment estimated at 5% of their 2020 expenditures, a 1.7% across the board rate increase authorized under the budget, effective July 1. And in addition, supplemental rate funding beyond the 1.7% to bring the waiver services to a maximum 4.5% total rate increase, including a 3.5% base increase and up to 1% in value-based payment increase. I know that some of you had questions about the value-based payment, and Dawn is here. She can help answer those. But in particular, we wanted to work with our providers on participating in race and equity training, connecting to our state's health information exchange, and beginning to implement the process of reporting on quality and financial data. For home health services, there's a similar one-time payment stabilization of 5% of 2020 expenditures, and then a maximum 4.5% rate increase. And then for pediatric complex home care health services, we know that that was a portion of this industry that has been particularly challenged. We know that there were some challenges with children being discharged from the hospital because of a lack of available complex home care services. So this particular part of the HCBS industry will include a one-time stabilization payment, the 1.7% increase, and then an additional rate increase under the investment plan, bringing the total to 31.7% rate increase for complex pediatric home health services. So I'm going to stop there. That's a very high overview of the DSS related investments. Again, I apologize for the scheduling conflict. I'm going to leave this in the capable hands of DC Mike Gilbert and Don Lambert, but I'll turn it back to you, Secretary, to walk through the rest of the slides.
Thank you so much, Commissioner Gifford. All right, we're going to delve into the areas of investment and try to get through this so we can get to your questions. The first area of investment is enhancing the home and community-based services workforce, $189 million. Commissioner Gifford talked about the temporary workforce and provider stabilization investment, which is a 5% one-time stabilization payment. I would note that these funds can also be used to support investments in the workforce. We know that it's difficult at this time to attract workers, and so the providers can use these funds in a flexible way if they wanted to provide retention bonuses or new hires to bring someone on board and attract them to the field. Commissioner Gifford went through the provider rate increases, and the other thing I would emphasize on this particular slide would be the investment in training. There is $2.2 million that is set aside to use a train the trainer type of model to integrate a racial equity lens into care delivery. And so we thought that was very important. We've started to do so in other areas of investment, such as in children's behavioral health, adult mental health, and some of our ARPA funds. And this plan also includes some funding as well to begin to integrate the racial equity lens. Commissioner Sheff, is there anything that you care to add with respect to the provider stabilization?
No, I don't have anything to add at this time. We, as the committee's aware, we're still implementing the wage package and reconciling that and waiting for a response from CMS on the submission before we articulate further how we'll utilize those funds. And other than that, I have nothing to add, Madam Secretary.
Excellent. Next is expanding and integrating the use of assistive technology, $64.3 million. $40 million of this investment would go towards the smart home technology investments in subsidized housing that you've heard us speak to. Again, that could be installing hearing device systems, converting TVs into video chat, smart doorbells. So 40 million of the 64.3 would be for the smart home technology. And then $24.3 million would go towards the assistive technology investments. Commissioner Sheff, do you want to talk a little bit more about assistive technology?
Thank you, Madam Secretary. So let me just offer that the scope of assistive technology on the slide in front of you is new and a lot of high tech. I want to make sure that people are aware there's a range of assistive technology from low tech to medium tech to high tech and comprehensive tech. And we'll be able to leverage these funds to expand use of those types of things. There are specific items that and folks need to understand that the technology advances daily. You know, we are aware of devices, the glasses that people who are vision impaired can wear that can narrate as they're moving around in their life what they're seeing through an audio channel. So they're really smart glasses. So instead of a whole house, you have an opportunity just to put a pair of glasses on that allow you to navigate more freely within your environment instead of relying on staff. In both the aging and in disability communities, things like hand tremors that would prevent someone from being able to feed themselves. There are spoons that work in such a way that they provide an opportunity for someone to feed themselves with a high level of dignity and reduces the reliance on staff to do feeding. DDS would be happy, because I want to leave a lot of time for questions, and there's a lot of areas to share more about the assistive technology world, both what's going on in other states, as well as the huge advancements DDS has made, and we have been participating in national conversations on assistive technology. We have some local speakers from the ARCs and the Tech Act centers, as well as DDS staff, and then some additional materials we'll be providing to the committee after the meeting today that just show some of the other strides being made across the country.
Great. The next category investment is to focus on enhancing self-direction. We recognize that there are over 7,000 consumers who prefer to hire and manage their own staff. This area of investment is to help to give them the greatest level of autonomy. So first, creating an employment network so that the participants can actually connect to direct career workers. It's a $4.4 million investment, help them to actually locate staff or find backup staff in an easier fashion. $2.1 million to support the electronic visit verification, a call center, so that there's a resources for consumer employers and the PCAs to go to ask questions relative to EVV, and to ensure that they actually have the technological support or technical support necessary to be successful. And then finally, we did feel it was important to include funding to support the fiscal intermediary to ensure that they have resources as well as EVV is implemented, but also just to bolster that program. As we know, we've had some challenges in the past. So being able to adopt EVV and process those timesheets might require some additional resources for the FI, and funds have been included for that purpose as well. In terms of our next category of expenditure, expanding environmental adaptations, I'm going to ask DSS to talk a little bit about the capable model. That is an evidence-based model out of Johns Hopkins. So over to Deputy Mike or to Dawn.
Good morning, Secretary. I guess I'll jump in first and then if that's okay, on the capable model. DSS, as Commissioner Gifford mentioned, was in a good position to be able to move forward with evidence-based models when we had the opportunity with the ARPA funding to connect all of the data that we've been looking at over the past couple of years with an opportunity to make some really good investments that are data-driven. The capable model is one of those. And this particular model, which has been tested and is being applied in quite a few other states already. What this really does, it's a person-centered, person-driven goal model that has an OT assessment involved and some visits from the OT. And then there's a follow-up, there's a team that also involves a handyman and a nurse. And basically, if the individual is open to having some assistance, they go to the member's home, they assess the home environment, they ask the person what their individual goals are with respect to remaining in their home, and they look at the environment itself about how it might need to be adapted to be able to support the individual's independence as they age in place. And then the handyman goes in and they make the modifications to the actual home. Generally, they're not very expensive. It's not a bathroom total modification. It's more that the threshold from the bedroom to the bathroom is a bit of a hazard because it's a little bit higher than maybe it needs to be. And the wheelchair or the other mobility devices are getting stuck on it. And so they remove those fall hazards from the home within about a 5-month investment. This particular program is going to target our existing 1915C waiver participants, so the home care program for elders as an example. It's also going to be an additional benefit available to those people who meet a certain need level within our Medicare savings program. So it's going to be a proactive investment, and we're going to be making those investments, and we're going to be tracking whether or not we've improved the quality of life of the individuals. We've improved their ability to be able to stay home if that's what they choose. And at the end of the time, it's really about that improved personal physical function. So Deputy Commissioner Gilbert or Secretary, I'll turn it back over to you.
Great. Thank you so much, Dawn. Next slide, please, Claudio. The next major area of investment is what we're calling expanding home and community-based service options. This is a $50 million investment, and it essentially has 4 components. First, we recognize that additional partnerships are needed in the community to address local needs. So a 24-hour backup, or if there's a need for a quick respite. And so therefore, there's a $9 million investment to establish these community partnerships. Then the next component of this category is a $10 million investment to provide 100 to 120 additional DDS placements, so to support the housing and the wraparound supportive services. Again, additional funding to support individuals being able to remain in the community. And then finally, I think we should emphasize here I think this is one of the transformative components of this particular category, to provide $30 million in bridge funding to help individuals transition to less restrictive settings. So I'm going to ask Commissioner Sheff to delve into this again to provide that temporary funding source to ensure that transition can actually occur and remove the financial barrier. Commissioner Sheff?
Thank you, Madam Secretary. We have for a number of years had periods of time where we have capacity within our system that doesn't get utilized in the manner we might hope. We also have a history of working to place people when they are perhaps at their worst as opposed to at their best. In that way, there's there's strong reason to believe that perhaps we're not always serving people at the right level, at the right cost, at the right time, in the right place. What has prevented us from being able to sort of work through those issues historically is an inability to assist providers financially as they're going through that type of transformation, identifying individuals who might benefit from a less restrictive setting, working with their families and their staff around reorganizing within their existing structure, and to break down some silos so that providers can work across corporations, across agencies, to make those mixes and matches work most effectively. The end result, we believe, if we address this in the manner that we hope, we will be able to assist people living the best life they can, as independently as they are able, and to look towards the wait list and the planning list at DDS to move people into other settings there they'll get the most amount of benefit. So we're really excited about this opportunity, and I think it, as other people have said, it's a pretty historic opportunity for funding and an ability to try things a little differently, and we're excited about that.
Great. And Commissioner, that's a great segue to have you talk through the DDS investments on provider infrastructure.
Thank you, Madam Secretary. And I may look to some help from my staff on some of these items, but essentially, without a stable provider environment, there's not much DDS is going to be able to do. So it's really important, and I know a number of you have heard from providers in your communities that are struggling through the pandemic, but even before, and even with some of the assistance we've given them. So there's a list of items before you on that slide that we think will help with better service planning and improved service delivery, improved billing, modernizing the manner in which we bill, the electronic systems, trying to do that in a way that is less burdensome and paper oriented, and will prevent audit findings and allow us to move a little more seamlessly. A move towards electronic health records. As I said, the governor has talked about e-government since his campaign, and that we remain a government heavily reliant on paper. And if we could participate in the electronic health records, allows real-time notification and current information available to all the people in the person's team, the providers in the person's team, modernizing our billing systems, quality reporting, and I think Commissioner Gifford began to talk about quality. I think there's an opportunity with these investments to think about quality different. I think historically, the state has looked at quality in terms of regulatory compliance. I think participants in Medicaid programs don't care as much about some of the regulatory requirements and would like us to identify quality in a way that means good outcomes for them, as opposed to meeting certain environmental standards. Not that those aren't important, but those aren't always measuring the quality outcomes people look for in their plan. I don't know if my staff have anything to add there. If you do, I'd appreciate it, but I may have covered that adequately.
Madam Secretary and
Yes.
Commissioner Chef, if I could interrupt for a moment, I just realized that you have 27 slides, and we're only on slide 14.
16, Madam Chair. There's an appendix. We won't be going there. We have 2 more slides, and we can probably wrap that up in 1 minute, if that's okay with you.
Okay, thank you. I appreciate it.
No problem. Perfect segue to quality, and we'll hit the highlights and let you delve into the details in your Q&A. $70 million investment in quality. 20 million of that is to create a quality improvement fund where we would solicit ideas from the stakeholders on how to improve quality, and essentially the proposals will be assessed based on their impact, and those resources would be distributed throughout the system. Second, a quality management toolkit for our clients, basically to create some web-based tools and printed material so our consumers understand the expectations for providers and who to contact when those expectations are not being met. Again, putting resources in their hands so that they can be empowered participants in the program. Third is to improve and expand the universal assessment system, to really expand our assessment tool to participants who receive services through DDS and DMIS, just to ensure that we have a more consistent needs assessment across the entire system. That's a $7 million investment. Modernizing our antiquated case management system. When you hear Commissioner Chef describe the current case management system, we are light years behind where we should be in 2021. These funds provide us with an opportunity to make this investment that has been critically needed and to ensure that we have real-time access to information and data so that we can also assess service delivery. That's a $34 million investment. $3 million for the critical incident management system, some enhancements to add more data into the system so that we can improve our ability to detect when there are issues and help us to identify problem areas and to mitigate incidents in the future. And then a small investment, but small but strong, $1.2 million to create a consumer quality satisfaction survey. Using the national core indicators, we'd like to have a survey to collect feedback about the quality and satisfaction of services. Again, kind of like a 360 degree view. We need that information to ensure that that participants are satisfied with the services that are being provided by DDS. $21 million for a value-based payment initiative. Again, these would be incentive payments to providers that achieve clearly defined outcomes. Those metrics will have to be developed. We'll use some national data, but essentially we want to incentivize them towards having better quality so we have a better experience for the participants across the state. And then there's $1.2 million to bring a consultant in to actually develop those metrics that DDS providers would need to meet in order to receive those incentive payments. Again, quality focused on performance and empowering the consumers to have the tools they need to have the best services with these resources that are being provided. And so let me very briefly conclude with this is a historic opportunity. Again, 10% match for a defined period of time. It allows the state to leverage more than $500 million over a 3-year period. And essentially it is at zero cost because the 10% becomes our state match. And with these investments, we've been very focused again on building off of the work that has been done over the years in the state of Connecticut. We had the opportunities, we had the ideas, now we had the resources to actually invest into these key critical areas. I will note that at the conclusion of this 3-year period, the ongoing cost of the state is $25 million. It's $50 million gross, but $25 million for the net state share. We are very strategic about looking at what the impact is at the end of these investments to ensure sustainability, to ensure that what we're investing in can actually continue. And so with that, this is a plan that gives individuals and their families greater choice and independence. It's expanding quality and giving them the supports that they need to continue to receive care at home. And also supporting the family caregivers that are a critical component of our system. With that, thank you very much for the opportunity to summarize the plan, and we welcome your questions.
Thank you, Madam Secretary, and thank you to Commissioner Gifford and Commissioner Chef for their part in this presentation. We really do appreciate it. I do want to acknowledge that we have been joined by the Chairwoman of Aging, Senator Miller, and the ranking, Senator Kelly, and Representative Wilson. Thank you guys for being here today. I'm going to ask everyone to raise their hand. If for some reason their hand raising is not working, could you just kind of wave and we will make sure that Heather sees you and acknowledges that you are able to raise your hand. And with that, we will move right on to questions. I would like to start with my co-chair, Senator Moore.
Thank you. Thank you all for this presentation. I think the wrap-up was the most important for me to understand that I've been asking this along the way about sustainability. Are we going to be able to sustain this after? And Secretary McCaw, you talked about that. I don't have any specific questions other than the racial equity piece. I'm so proud that you have include this across the table, that it builds that equalized understanding of how race impacts us across the board. And I hope that we will be doing that in all of the commissions, looking at that. And so you mentioned that you're going to do this. Have you started doing this do you have an organization doing that work for you?
I'm going to ask a DSS or DDS representative if they want to talk in a little bit more detail about any progress we've made to date.
So Dawn Lambert, DSS, I'm happy to take that question, and I'm really excited about a lot of things in the ARPA plan, and that's one of the more exciting transformative things where we think we'll be able to lead provider performance and result in better outcomes for all of our participants. We plan to have consultants go ahead and build out the plan. We have learning objectives already defined. The work on this was actually done during COVID-19 about a year ago in partnership with the Center for Medicare Advocacy. There were work groups that were aligned. They built out the what if scenario, what we would do and how we would do it if we received funding. So the learning objectives were not new. They were part of a very thoughtful process with stakeholders. We were just excited to have the opportunity, but we have not yet hired the consultants. We're waiting for the actual permission from CMS to move forward. We do not yet have the funding. So we're getting as ready as we can. We only have three years to do it, but we need to wait for the actual funding to actually start the hiring.
If I can, Senator Moore from DDS, outside of the ARPA funding, we have just closed a posting and are interviewing for what will be our first diversity, equity, and inclusion director. They'll have two charges on behalf of me. They'll report directly to me. One is to evaluate, develop programs, develop training on the staff side internally at DDS regarding diversity, equity, inclusion. And the other half of their job will be to look at service delivery and Medicaid beneficiaries to make sure that there's equity in the system, to take a look at data that may relate to use of meds, levels of funding, types of settings offered, level of independence, quality outcomes, and really make sure that our service delivery system has the kind of equity it ought to. Some of the staff side will be to try and ensure, along with our CHRO and AAEOE folks, that that people are likely to receive supports from people who look like them, and we don't always look like that. So there's a lot of work to be done there. That's outside of the ARPA funding, but bringing that staff in will allow us to use the improved data that we'll get from the modernization of systems and other initiatives to really advance that within our system.
So, Madam Secretary, so is that diversity, equity, inclusion going to be across all of the commissions that someone's doing that, or is that a single person for each commission?
The Commissioner Chef was speaking to a hire he's making within his agency that will be will be helpful from a staff perspective and a programmatic perspective. Many of our state agencies do have diversity, equity, inclusion type positions, or it is a component of the HR team. We have, however, recently done an RFP and obtained a nationally recognized expert in DEI training, so that every state agency has access to bringing in a trainer for their state agencies. I think we're at the beginning stages of more consistently building in a racial equity lens across our programs. You'll recall that Commissioner Durantes in the ARPA plan, and the legislature supported this in the allocation. There is funding to start to build that into some of the children's behavioral health programs, particularly kids that are coming out of trauma type incidents, where we felt it was critically important that the providers understand some of those cultural and racial sensitivities in order to appropriately and successfully reach the child. So I'd say that when we look across the array of programs, we're just beginning to incorporate this type of training and lens into the work. But there's also a bill, and it might have been in the implementer that passed the legislature, whereby the administration is tasked to look across the Health and Human Services programs and begin to evaluate some of these racial equity components. It's big, it's still being defined, but you charged the executive branch with going deeper. Granted, there are some agencies that are starting this process, I'd say on their own, but you did task the administration to begin to look across the programs and to look to begin to evaluate racial equity. And so that work is just beginning from an implementation perspective.
So this plan have to go to the federal government and then come back, or is this the final plan that you've put together?
The plan was submitted to the federal government on July 12th. We have not yet received approval. Dawn is on the line. I believe Washington was one of the first states to submit their plan, and within the past week or so, they just received their questions from the Fed. So we're waiting whether or not they're going to approve, or will they have some questions or some follow-up for us.
Thank you. Thank you, Representative Abercrombie.
Thank you, Madam Chair. So some people are having problems with their hand being raised. So I'm going to skip around a little bit because they had texted me earlier. So I'm first going to go to Representative Walker.
Thank you, Madam Chair, and thank you, everybody, for the presentation. I want to thank you for continuing the conversation about the ARPA investments, especially with the home and community-based services. When you receive the clarifications from the federal government on how the ARPA dollars are supposed to be spent, the scope of work was defined at that time when you submitted the plan into the feds, and you also defined the impact that COVID had on these services and these agencies when you submitted that application. Is that correct, Madam Secretary?
Certainly, we did have some general information. For example, they are very clear about these have to be qualifying investments back into the system. Right. This is somewhat different than what I think you're referring to as our ARPA state fiscal relief funds, where a clear connection to the pandemic has to be established. This particular pool of ARPA funds has a little bit more flexibility. They allowed the state to define some of those investments. But Dawn, I'm going to ask you to give Representative Walker a little bit more detail in terms of the scope that the feds provided, and as it relates to the plan we developed.
Thank you.
So the funding was made available to states for two primary reasons. One is to address weaknesses that emerged in the HCBS infrastructure or unanticipated increase in demand on the HCBS infrastructure, specifically because of COVID. And that absolutely happened here. Our dashboard is about to go out. I will tell you, after tracking for the last 15 years, discharges from hospitals and where people go, seeing a minor incremental increase to community versus nursing home, 1 to 2% at the most per year, generally 1%. When COVID started during that 6-month period, 6% increase in discharges to community. And so what that means is the infrastructure in community is very weak. So if that was one of the primary reasons, is get support out to support up the HCBS infrastructure. There are thousands more people who otherwise would be in nursing homes who are currently in the community. So that's the urgency there. The other part was overarching rebalancing. So it's aligned, but it's really taking the urgency from COVID, adding urgency to your rebalancing plan, and making that transformative leap that Commissioner Gifford talked about. So because we already had a plan, we were in pretty good shape to make those investments and leverage. It wasn't a thoughtless process. It went for about a week. We thought about it, and then we realized we already have the plan. We've been talking about this. It's just that the question is, what became more important because of COVID? What did we learn from COVID that now we can integrate and really strategically focus on those areas that were already in the plan, already data-driven, just shovel-ready? So two primary reasons: COVID and rebalancing.
So when you talk about the fact that you saw that 6% was the achieved number, what has happened to money follows the person? We had an investment in a plan and a program called Money Follows the Person that was supposed to do exactly what Commissioner Sheff said, which is to move people to a less restrictive living requirement and out of nursing homes and get them out of state agency or funded programs and get them on an independent area. So what has happened in that, on those fundings that we had in the budget, many years that we've been supposedly working off of?
It just became more important. We flipped Money Follows the Person to a total virtual system on March 16th, 7 days after the governor said there was an emergency. We were ready. We had an assessment that we could go web-based. We shortened it. We made it possible for virtual. We stood up the entire training for all staff within 1 week, didn't miss a beat, and transitioned from nursing homes 15% more people than the prior year. So Money Follows Person is now back in homes with a lot of protocols in place that we didn't know we needed 3 years ago or 2 years ago. It just became more important as a tool that we already had in place.
If I can add, and I'm not sure if Krista's on the line, I was actually surprised at some data that Krista shared in terms of how successful we were in continuing to move people through the system during the pandemic to less restrictive settings. And Krista, I don't know if you have that, any of that information readily available, or if you can just talk about it generally.
Yeah. Good morning, honorable legislators. So I apologize, Commissioner, I don't have that information available at this moment, but I'm happy to provide it to the committees after the meeting for additional follow-up. But I do think that the information that was provided does show that there were still really good outcomes that occurred with transitioning people to less restrictive settings throughout the pandemic. Obviously, like Don Lambert mentioned, there are many more protocols in place to ensure that it was being done safely, but we still had some very important successes that improved the people's lives that we were able to work with. So I'm happy to pull that information and send it around to the committees after this meeting. Thank you.
Thank you, Krista. I guess what I'm trying to make sure is that we had a program that was, I thought, working, and we are putting more money into it, which I don't think is a bad thing, but I thought that we are trying to plug up those things that we saw as a no, not a flaw, but flaw that we had not been processing. And so I'm just curious, when we talked about the scopes and everything like that, did we check the data on what we've already done in these areas as we chose the paths that we were going down? Secretary, go ahead. Yeah.
Yes, and what I would say is that this builds off of the Money Follows the Person program, in that now it's giving us additional tools and resources to still invest in that long-term rebalancing. And the feds are saying, yes, we have some programs in place, but we need more, because we recognize the demand has increased because people are now desiring to be in the community more. So Representative Walker, I'd say they work hand in hand. Those investments are still needed. They're still being leveraged and utilized. And now we want to build off of that.
Okay. All right. I'll stop. But could we get the slides and the details that you're talking about and sent to
Ms. Keene?
Ms. Keene, and make sure that Krista's information also about what's going on with them. So
absolutely.
Thank you, Madam Chair.
Thank you, Representative. Just for clarification, Claudio did send to Heather the slides. She will be sending them on to the Clerk of Aging and to Sue Keene for approach, so everybody will get a copy of that. So thank you, Claudio. Appreciate it. Senator Austin.
Thank you very much. I'm going to build off of Representative Walker's questions. And first, we did talk about the other day when we had a briefing on this, that many things were going to go to technology, from low technology to more comprehensive technology. I have said before, and I still remain unconvinced that we are not putting people at jeopardy to be more isolated by putting them in individual apartments with technology and no human contact. I think that that's a bit of a problem. And there was an answer that was given then, and I just would like that answer shared again relative to the technology. And I think it was Commissioner Shep that gave that answer then.
Yeah, so I appreciate the opportunity, and I look forward to the opportunity to convince you otherwise, Senator Ostin. And we've been doing some research to bring some specific data around the fact that technology actually has an opportunity to decrease isolation. And I think there's some specific pandemic evidence that we'll be sharing later on today as we pull that together. I think in Ohio, which led intellectual and developmental disability organizations across the country on a technology first front, is that they say technology first, but not only technology. So we're not looking at technology only solutions. This would be to supplement and expand the opportunities for people to use the people resources in their life differently, that might actually promote more community integration, more community involvement, and more being in relationship, instead of utilizing all of their funds for things that technology might be able to provide. And I think I gave an example the last time. If someone through a program was determined through the assessment process to get 16 hours a week of support, but they had a complicated medical regimen in terms of how they take their medicines. Right now, they probably, because of you're taking medicines every day, you need someone to help pour them, pass them, make sure that you took them, make observations around after you've taken them. If those 10 hours a week could be reduced to just a few hours a week because of technology that could do it at a fraction of the cost, that same allocation of hours could be repurposed for other outcomes within your plan. So you could move things around within your plan and use them differently. I didn't articulate that as well as I did during the small briefing, but I hope I got to what you were getting at, and I can clarify further if I missed that.
No, that's essentially what you say. You talked a little bit more about someone who has tremors and eating, and someone who has seizures and is sleeping. But I just wanted to put that out there. I'm very concerned that what will end up happening is that technology will replace the hours necessary for other things, and that we will look at ways to decrease the hours that are given to people and say they are getting these hours now because before they needed help eating and now they don't, so we're going to cut 4 hours here. Before they needed help taking medication, but now they don't, so we're going to cut some hours there. Before they needed someone who was going to be there at night to watch their seizure activity, now they don't, so we're going to cut some hours there. And that is my real concern, that we're going to use this technology as a methodology to decrease individual care.
Yeah.
So I look forward to the increased conversations about this, but I remain concerned. The habit of the way we handle those with intellectual and developmental disabilities and other people that we take care of is to do always to do more with less, and the less will be that individual worker that is providing a little bit of help with people. So I just that's my concern there. Does this program help out those with mental health issues? Because generally they're not on the same rate structure. So is this just for certain job classes? I don't know who to ask that question for. Dawn, you said no.
Sure.
What was the no
Yes,
to? Does that
It
mean
is not just, it does include people with mental health disabilities and their workers.
okay, so if we have someone who has complex care issues and they are, whether a child or an adult has a worker that comes by for mental health issues, does that mental health worker see an increase in their pay relative to the concerns that we have here?
Mike,
It's your question, Senator. Are they receiving some of the rate increases that are in the plan? Is that what you're asking? Yes. Demas,
can you send us a chart on the job classes that are getting the rate increases? Because it's hard for me to tell which job classes are getting the rate increases. I know it's crystal clear to all of you who have been working on the plan, but I don't see which job classes are getting the rate increases. And I'm trying to make sure that we're not leaving a job class out as we move through this process. And I also have a question relative to, and I think that Kathy Abercrombie is going to tell me you've asked your 2 questions. I'll ask one more and go on and hope other people have questions. I may have questions at the end. Relative to the workforce, is there a plan to make sure that we're dealing with the compression component of the workforce so that we're not just taking care of those at the low end, but you know, the Appropriations Committee spent a lot of time working on making sure that we were providing resources for workers to see an increase in pay so that they would be successful. That increase in pay, it appears to have gone to those at the lowest level, and we're missing that middle level worker who might have been in this field for 20 years or 10 years and is not seeing an increase in pay. And the compression that the secretary has talked about relative to state employees is now becoming, I think it's always been a problem, but is now becoming a problem relative to our providers for those middle level workers. And then I again appreciate the slides and all of that. I do have other questions to ask, but that would be my last question right now.
Yes, Senator, we will ensure that you receive all the backup with respect to which DMIS providers are benefiting from the rate increases. With respect to the compression, we recognize that that's a valid area that we're going to need to take a look at. As part of this process, we've learned that we do need to update our internal data on our contractual workforce. So that once these rate increases are provided, we can then begin to look at, you know, years of service relative to the hourly rates of workers in similar job classes. There's nothing in the plan here that would address compression, but we do recognize our starting point is the data. And then we'll have to sit down and begin to discuss how it is we begin to address compression in the long term.
Thank you, Senator. Representative Hughes?
Thank you, Madam Chair, and thank you for the opportunity to have input and oversight into this plan from the legislative body. I really appreciate it. Couple of quick questions. You said 100 to 120 additional placements through DDS will be provided. Does that reduce our waiting list? Can anybody speak to that?
Commissioner Shove?
Yeah, that would be the intended goal. Yes.
And do you know what the waiting list is now? That's one question.
You should have done an A and a B, Representative.
I know, right?
So as traditionally has been defined with the legislature, we're pretty consistent with where we've been at a wait list of around 600 in terms of people who are either emergencies or priority 1, what we would call urgent now. We have an additional roughly 1,400 people on what we call our planning list, people who are a year or more away from needing placement.
Okay, so roughly around 2,000, it's kind of stayed the same, but this would reduce it by 100 maybe. Okay, great. I also wanted to build on some concerns about well, first of all, I love the environmental and home adaptations and to spread that out to more than just the Medicaid eligible to the Medicare home care savings, because low tech, reducing fall risks, making safety modifications are so important to saving costs and harm in the long run. I'd like to see a little bit more thinking broadly about the smart technology and assistive technology working in both the aging community and the DDS community. Boy, low tech solutions end up going a long way. I love the idea of smart technology for like medication distribution, but I echo Senator Austin's concerns that if we can redirect some of those savings into training the workforce or supporting the workforce in self-determination of the client, but also engagement and connection and autonomy to go and do those other higher level things, because we see so much how isolation takes its toll. The third thing with smart technology, is there also a option or even initiative to provide hardwired high-speed internet and reduce wireless, RFR, dirty electricity in the homes. That's my question.
Commissioner Chef, I'll jump in. Our plan doesn't really get at access, but that is a strong theme coming out of Washington. So you raise a valid point. One, let's talk about where we have opportunity. We have some opportunity to think about how to look at this particular need, perhaps depending on what we mean, if it's infrastructure oriented as opposed to subscription based. But in any event, we have the Capital Projects Fund that is a separate ARPA funding source that is focused on connectivity. There is some funding in there that looks at providing some investments to connect from the curb to the actual wires and the infrastructure that could benefit this particular population. And then there's a significant infrastructure bill that we expect to come out of Washington. We'll have to take a look and see if there are some opportunities here. So thank you very much for raising it. We'll have our teams dig a little deeper on that particular recommendation.
Okay, great. Because as we see with, internet stability and power stability, are having managed group homes and supported living apartments, when these extreme storms come down, it's really leaving our most vulnerable extremely vulnerable. That's why low-tech solutions are the first wave of really creating that kind of assistive technology that really works in a lot of across the lifeline, and that's our lifeline that we want to first and foremost maintain. So I just wanted to sort of get that out to more people versus really high tech solutions to fewer people.
Thank you, Representative Hughes. Representative Dillon?
Thank you very much, Madam Chair. Thank you very much for your presentation. There's a lot here, and I enjoyed the slides. Although we don't need to go through all of them, it's not clear to me if we look at the budget that we passed, where the dollars that we put into providers actually went, as opposed to where we thought they were going to go. And some of the holdbacks, whether or not there are going to be ARPA dollars available for behavioral providers, and that would be specifically mental health and substance abuse, which had a lot of cuts. It's not in here. They may not be in the waiver, but what action are you going to take to provide some kind of relief to the behavioral health providers?
Thank you very much, Representative Dillon. Great to see you today. So first, we strongly believe that additional investments in the area of adult mental health are necessary. We know that COVID has exacerbated the demand for mental health services. The governor did include a request when we submitted his allocation plan for the ARPA state fiscal relief funds for I believe it's a $10 million investment in adult behavioral health. That did not make it into the final allocation plan that was approved by the legislature. However, it is our intention to continue that discussion. We'd like to see that investment. We do have some additional funds in ARPA that did not get allocated. And when the legislature is reconvening, whether it's a special or regular session to address that remaining balance, we'd like to see the adult mental health funding actually allocated. We did have funding on the children's behavioral health side that made it into the allocation plan, but the adult mental health investment was missing. So we will need to get those funds back in so that the full spectrum is receiving some support.
Thank you. Just to look at the cuts to the grant accounts and other funds over a period of time, they started behind. And ironically, the reductions in force that some of the providers had to take meant that many of the young people that I knew that really may even have changed careers were people of color who had gone to taken out loans at graduate school to become social workers or so forth, and then had their hours cut back because the state was cutting back on mental health or substance abuse. And so I don't know if we always put those things together when we're putting a budget together, but anyway, thank you for your answer, and we'll continue to talk about that. I know that's outside of, I'm interested in the technology aspect and concerned, Commissioner Chef. It appears sometimes that we're in constant quest of a way to provide services on the cheap, as cheaply as possible. And I want to make sure that we, whether we're talking about developmental or we're talking about behavioral, are also helping to strengthen family resilience. Having said that, are you or Dawn Lambert thinking about ways of expanding the ways we define caregiver? That is, have we looked at men? Because historically, one of the predictors of whether or not someone goes into institutional care over time very often had to do with whether or not they had a relative nearby who was a male versus a female, a son versus a daughter. It may be that patterns are changing, but I don't know that. And this may be more Dawn's bailiwick than yours, but I think that it works for both.
I'll turn this over to Dawn in just a second. I do think that at the federal level, there's reconsideration on who can be a paid caregiver. That isn't formalized yet, but I know it's a topic of discussion. And I think that the pandemic escalated the focus on that, as many, what Dawn refers to as informal caregivers might be eligible for in terms of compensation, and who might be available to provide that service. I think that's what you're getting at. I may have misunderstood the question, but I think Dawn has more information on that whole informal caregiver concept.
Right. So thank you, Representative Dillon. First of all, let me assure you and others that are concerned about assistive technology, about the framework of this entire plan and the principles that Secretary McCaw talked about in the very beginning. We did not suggest any investment of ARPA dollars that did not have the aim of improving the quality of life of the people that we serve, first and foremost. Whether it saved money or it didn't was irrelevant if it didn't improve the quality of life. And therefore, we know that's choice, autonomy, independence. Those things go along with it. They also improve health outcomes. But if our investment didn't improve quality of life, it wouldn't be something that we had recommended. And we will definitely keep track of that along the way. It is not a savings initiative first at all. Do we think there could be some efficiencies? Some efficiencies, yeah, that give people more ability, maybe for additional community integration, depending, but it has to do with the goals of the person. And with us providing a package of service that actually helps that person achieve goals. There are individuals who would prefer not to have as many, so 24-hour caregiver to us makes us feel great sometimes because we perceive safety. We have some people that we serve that do not want somebody watching them 24 hours a day. They just want a little space. And as long as it's still safe and we have a way to do it that allows them the choice and the autonomy to do it, that's where we're going to position the assistive technology. With respect to caregivers, you know, I think that's a very interesting question to track, and I'd love to be able to track that as we go through the next 3 years, because I don't know if there are more men who are caregivers now than before. I suspect that there are. And do they need things differently than the traditional informal caregivers that were more often the daughters or the moms? So I think we need to track that, but certainly men, anyone who is not paid, who's supporting the participant to have that choice to stay home in a meaningful way, all of those individuals are considered informal caregivers. So they're all part of the target population for many of these additional investments, the accessibility, the environmental modifications, the assistive technology, all of those really have one primary target, and that's to shore up our informal caregivers that I think we have exponentially more today than we did 2 years ago, because they're the ones that are providing the support for people to stay at home. So I think we can track whether or not there are more men. I think it's an interesting question, and I look forward to having that be part of our research over the next 3 years.
I think that was my 2 questions, Madam Chair. Thank you very much.
Thank you, Representative. Representative Dathan.
Thank you very much, Madam Chair, and thank you to Secretary McCaw and Commissioner Sheff for your presentations today. It was really helpful. I'm going to align for my first comment, my comments along with Senator Austin and Representative Hughes. I have some pretty big concerns about relying on technology to do some of the services that really should be a bit higher touch. I've spoken about my mother who suffers from memory issues, and her big decline during COVID was the lack of face-to-face care that she received, not due to lack of the providers. It was just the trying to keep the elder community safe. So I do worry that we are trying to be penny wise and pound foolish here, that we need to be thinking about not just our seniors here, but people who are in the IDD community that need that sort of constant social interaction. And while we might be relying on some things for technology, we may be putting these people at a bit of a disadvantage. So I would like to hear some data that the agencies have to support that outcomes for these individuals won't be hampered. Presumably, there is supporting information from other states that have done this, and would love just to get a bit more data to get some understanding on ensuring that our vulnerable are okay. So that's my first question. My second question is, I have a number of constituents who are in the IDD community, and I'm a little concerned that we haven't really focused in on some of the details about the proposed changes here. I feel like it was kind of a little bit, maybe a bit more higher level. And I really want to understand what these changes would have on a family that has a child in the IDD community and how they're going to be served. And if any sort of public consultation or any discussion with these with members of this community has been had, because we just need to make sure that that we really are, we talk about funding quality improved initiatives, but I want to make sure that the outcomes are there, and I'm not entirely clear at the details based on the presentation today. So if you could focus on that for me, I'd greatly appreciate it.
We can provide some of that background for you. I want you to know that for DDS's portion of the ARPA funding, we relied on inputs from the Alliance. We heard from the ARC, which represents families. We heard from other family groups. It was a very short amount of time to turn around a pretty complex document. My typical approach is to try and socialize these things and have the broader stakeholder input than I was able to this time. However, after submission and in collaboration with DSS, I've held a series of 6 or 8 town hall meetings virtually with broad attendance with families, with staff, and with providers. The second stage of those is scheduled for September, where we will have smaller community-based conversations that'll be more interactive than the presentation I did on some of the end of budget and beginning of FMAP funding that I did in a more presentation style over the last month. So we have tried to be as open to conversation and inputs as we can. I hear from families every single day directly, respond to many of them on my own if I have the answers or find them assistance when I can. And we spend a lot of time, DMIS, DCF, DSS, and DDS talking about children specifically because they're identifying their primary needs and how their primary services might be provided is complex because there's a large array across 4 state agencies at a minimum, not including private insurance and private pay, that may be available to them. And we meet in a variety of ways on an ongoing fashion, including inputs from the Office of the Child Advocate.
Yeah, I really would like to see the details behind that because I am just not entirely clear. So I appreciate you doing that. And I will be reaching out to the Nonprofit Alliance, and I have a very good contact at the ARP who is a constituent, and will be reaching out to him because, you know, this is just a concern of mine, and I'd love to get some more details. So I appreciate if you could forward that to our administrators. Thanks so much. Thank you, Madam Chair.
Thank you, Representative. Representative Porter.
Thank you, Madam Chair, and thank you, Madam Secretary and team. I just want to piggyback off of what Representative Dathan was just talking about, because I too have constituents that have concerns around the IDD proposals, which there are some pretty significant changes in this plan that are being proposed. So I just want to reiterate, you know, if we could get in detail, you know, an outline of what these changes would mean in terms of the experience for the people and the families with IDD, and also the providers that serve them. And then if we could get a list, because you did, the Commissioner, you said, you named a few folks that you spoke to so far and that you're going to be speaking to other stakeholders. If it's possible, could we please get a list of the stakeholders that you've currently had contact with regarding this plan? Because I just want to make sure that the folks that are reaching out to me, if they haven't been included, I can submit them to be included. And then I'll give you 2 questions for
Representative Porter, I think you just muted.
Robin, you muted yourself.
$5.5 million to hire 10 new
Robin?
staff, $5 million to create.
Can you repeat your question? You had muted yourself.
Oh, I didn't do that, but okay. I was just going through the fact that there's a lot of investment in the state government, talking about the millions that are going into, you know, new case management system, business intelligence software, UConn evaluation. And I'm just wondering, you know, how much of the total funding is going to be spent inside state government, if we could get a breakout of that. And then also, if you could speak to how much will go to the community-based Medicaid providers, you know, that for years and years, you know, have been on us to increase their funding. That's a big concern. So I want to see if you could speak to those 2 points for now. Thank you, Madam Chair.
Thank you. Thank you so much, Representative Porter. And I'll start, and then I'll tip it to the team. And we're happy to do a follow-up in our 7 areas of investment and break out for you which of these go directly to the community versus what is supporting kind of behind the scenes infrastructure. But I would say the items in here that are directly going to the community, $190 million in workforce is all going to be the stabilization funds, bonuses for recruitment and retention, the rate increases, which are permanent for the providers, supporting caregivers. Again, these are direct investments going to the community. The $64 million in use of assistive technology. Again, those are investments that would be made. I would view those as funds going directly to consumers to avoid costs that they would otherwise have to bear. So that's $64 million. The enhancing self-direction, these funds don't necessarily go directly to the consumer, but having a technical support and being able to pick up the phone and call someone and say, I don't understand how to use EBV, or for that employee to be able to do so. We view that again as an investment that directly benefits the consumer. And so that is a $12 million investment. You have the environmental adaptations. Again, the team would go in and look at that apartment, the nurse, a facilities type person, and figure out where those areas of risk are, maybe for fall or to prevent fall, et cetera. Those are costs that the consumer would avoid. That I see that as an indirect way of putting resources right into their hands. And then I think where we have to delve a little bit more, the items I just described, that's well over $275 million. We can kind of go through the technology pieces, pull them out, and show you how much of that is behind the scenes infrastructure. But again, if we don't have an adequate case management system or an incident management system to identify trends or where problems are occurring, then we can't indirectly help those consumers. So technology sometimes looks as it's just going to state operations, but the investments that are in this plan are all geared towards making sure behind the scenes we can serve our consumers and our participants appropriately. And then lastly, the quality bucket, that's $100 million. I view that as dollars to the consumers. It's not dollars in their hand, but it's making sure that the care that they're receiving is the best care possibly that can be provided. And those incentive payments are critical to getting folks to meet the quality outcomes that are national best practices. So we will definitely do the follow-up. I know that the environmental adaptations and the assistive technology that you've expressed some concerns, and the commissioner will do some follow-up. But by and large, the vast majority of these funds are directly benefiting the consumers or the employers in a direct or indirect way, and not so much about supporting state agency operations. Our intentions here are really to make meaningful investments directly that benefit the consumers.
Thank you, Madam Secretary, for that clarification. I do appreciate that, and agree with some of the reasons that you stated. And I know that we definitely need to do a deeper dive, because you touched on, the rate increases, and one of the questions that I'm being asked is, which rates are being increased and by how much, and we have home and community-based services. Are they included? The increases, are they limited to a specific area? We got those that bill Medicaid directly and largely outside of the Medicaid waiver. So there's all, what they say, the devil is in the details.
Of course.
And we're being asked about the details, because people really want to understand, if the increase is only meant for one specific service type, example, PCAs, if it is, why is it limited? All of these kind of things. So I won't take up any more time, because I know there's probably other folks in queue with their two questions, but if time allows, I will definitely like to circle back just to see if I can get some answers today on some of the questions that are being presented. Thank you, Madam Chair.
Thank you,
Madam
Representative.
Secretary.
Thank you. And we will make sure we have sent over a summary of the rate increases by provider type. And that has been provided, but we'll make sure that it also goes to you directly again, so that you're able to respond to your constituents. We've detailed those rate increases. And if there's any additional follow-up, the team stands ready to support you in getting those questions answered.
I appreciate that, Secretary McCall. And the last thing that I will say is, as the labor chair and someone that deals with the workers, right, in this system that provides these services, I think we need to speak to, pay rate, pay increases, and things of that nature for them, because there is, as we all know, we're having a hard time getting people to come back to work, and we have a hard time with new hires. And I think that, we really have to be honest about the pay rate, what people are receiving, not livable wages, to do a very tedious job, and a labor of love for them, but, love doesn't pay the bills. So I would like to talk about that as well. How we're going to help these workers, essential workers, right? We call them heroes. We need to make sure that they're not just being applauded as heroes at work, but they can actually go home and be seen as heroes at the table, right, as providers. So thank you again, and thank you, Madam Chair.
Thank you. Thank you, Representative.
Representative Belinsky.
Thank you, Madam Chair. I appreciate the opportunity to ask a couple questions and speak, but I want to also thank Secretary McCaw and Commissioner Chef for the preparation that's gone into this. It's interesting. One of the fun things about Zoom meetings is when you just getting geared up for your questions, the person before you reads your mind and asks many of the same questions. So both Rep Dayton and Rep Porter covered a lot of the ground that I'm going to, so I should be quick. You know, as I look at the proposal, you know, it just appears that it's lacking just a little bit of detail, and it's great to hear, you know, from Secretary McCaw that you know, she's already in the process of anticipating that and reporting. So I thank you for that. But you know, the one of the things that's important, particularly for those of us that live outside of the major metropolitan areas in the state, is the way we administer this. And again, Secretary McCaw, you've already addressed the fact that we're not, you know, addressing only state agencies in this, but I'm just sort of curious as to the input, you know, the robustness of the input that we've seen from our community, you know, nonprofits, because, you know, when you get to places like Newtown, you know, or, you know, at any place that's not in a metropolitan area, your services are provided by, you know, by nonprofits, and they're serious stakeholders. And as you said so eloquently, Secretary, you know, this is all about delivery of services. So, you know, it's actually refreshing to hear, yes, we're going to spend some money on a contact management system so that we can serve as many people as we can without, you know, getting stuck in our underwear, which is, you know, what we've you know, done as the system's been stretched. But a couple quickie questions. But when it comes to services that are very important in my community, you know, in addition to the IDD issue, which is always there, behavioral health care, you know, that's being delivered by our nonprofit partners, you know, is that going to be robustly, you know, supported in this plan, and how aware are they of how to access the resources? And then when we talk about the money that's being put into the temporary workforce and provider stabilization, you know, we're seeing people that, or seeing organizations and businesses that are stretched to the point of not being able to, you know, as Rep Porter said, find the help that they need to provide the community support that is very necessary right now, coming off of, you know, a year and a half of isolation. So how do the providers that are non-state agencies access that funding, and when might it be available? That's it. I'm done. Thank you.
Thank you so much, Representative Belinsky. Let me begin with your last question, and then I will have the team talk with you a little bit about access. First, obviously, we will be awaiting the feds. Either they might have additional questions or look for modifications to the plan as presented to them. And after that process is concluded, obviously, we need final approval from the feds before we can begin to implement. And so we do believe that we're probably a month to 2 months out. And so at that point, then the agencies would begin to operationalize and to get any necessary provider bulletins out and engage key stakeholders. But I'm going to ask Dawn, if you or Commissioner Chef, do you want to go into a little bit more details about our plans for continued engagement during this time frame to get some input from the stakeholder community, as well as touching upon any of the behavioral health components?
Thank you, Secretary McCaw and Representative Belinsky. I articulated earlier, we have had, I've spent portions of the last month engaging directly with stakeholders, including the providers. giving them an overview of the funding. It follows inputs from their trade association that we considered when developing the plan. And we have conversations planned throughout the month of September. That'd be just the first step, and we'll continue to do that. We continue to have these conversations even though we don't have final approval or all of the details and the interchange between CMS and the state in anticipation of what we expect to be approval upon negotiation, and then we will have to very rapidly move to implementation. So we're beginning those conversations even in advance, and I'll turn that to Dawn for any additional feedback on that.
And Commissioner Sheff, if you could comment on your engagement thus far, the level of support that you're hearing from stakeholders or areas that they might find need to be addressed in the plan, that might be helpful for context.
Sure. I engage directly with John Carl Casa at the Alliance and Wynn Everts at the ARC. I have a DS council that is made up of representatives of DDS Families First, the ARC, people who are loved ones of those supported in public, and people living independently. So we have a pretty broad set of inputs. I've had an open door for the last 4 years and will continue to have an open door for any input. 1199 has been part of the conversation as our largest representative bargaining unit for the private providers, as well as I believe our largest bargaining unit internally. And that's, off the top of my head. We'll take a look and make sure that we've covered all those bases following the meeting.
Dawn?
So similarly, we have networked with some of the same organizations that Commissioner Sheff talked about. The actual steering committee that I would say is the primary leader with respect to stakeholdering and setting things up is co-chaired by the state's ombudsman and the past president of the ARC. So there's a lot of diversity within that steering committee, including the people that we serve themselves, older adults, people with disabilities, but it is cross disability. It includes people with mental health disabilities. It includes people who are representative of people with intellectual disabilities as well. That the plan is for it, which has been a longstanding practice, because this is the group that also advises money follows the person. They have a lot of experience with providing input and advice. And frankly, they know that they literally advise us. It is not just a meeting that we go to. We actually jointly do a lot of things. And that, I believe, is really the primary reason that the state's Money Follows the Person program is successful as it is, because it has ongoing stakeholder input. The plan is to actually set up work group structures like we always do with a diverse group of people. And in those diverse, that will include some providers to actually get into what are the design elements. So Representative Belinsky, you said there aren't a lot of details. There aren't, what you saw in front of you, it's not a detailed action plan. We will be working through the detailed action plans for every single one of those initiatives with diverse work groups that will be part of the actual design, and then we'll help oversee the implementation. So University of Connecticut reports will go back to the work groups, and they'll be continuing to advise whether we need to revise what we're doing or whether we continue on track. And I'll defer to Deputy Commissioner Gilbert on the timing of funding for people with providers with behavioral health disabilities.
Great. Thank you very much, Dawn. I might also suggest that, the legislature, perhaps our most active special interest caucus is the IDD caucus. Does an awful lot of advocating for folks with, with mental and developmental disabilities. If we're not engaging and at least talking or reporting to the chairs of that caucus, that would probably be very helpful as well. But thank you very much for having considered all of this and having an answer so quickly and readily available. I appreciate it.
Thank you.
If I could just step in for a second to just touch a little bit upon the timeline aspect. I would just like to mention that obviously plan approval is paramount and will be a kickoff to activity in this space. But the other piece that's also going to be very important is a lot of these actions are going to require waiver changes, and those waiver changes have a legislative process associated with them. So we will definitely be, looking to your leadership and assistance with trying to move those through the process as quickly as possible so that we can limit the time frame, to implementation, recognizing that provider stabilization is of extreme importance to all of us collectively, to try to be able to take those actions as quickly as possible. We will need your support in terms of those waiver amendment reviews and approvals. So I just want to mention that we're working very hard to make sure that we position all of the rate increases for action as quickly as possible, but there are some dependencies in there that we'll need to work with you on.
Cool. I'm sure that Chairwoman Abercrombie and Ranking Member Case are eagerly waiting to get the legislative piece moving before we come back into session so that we can come right out of the box swinging.
Thank you, Representative. We're going to continue with people for the first time and then move on to colleagues for the second time. Representative Case.
Thank you, Madam Chairwoman. And it's almost good afternoon, but I just want to mention a few things that I've been hearing here. And I think Representative Abercrombie will agree, when we started to go into EBV, and this is to Secretary McCaw, EBV was really to save us dollars in the long run. And now we're seeing, what was it, $12 million being put in to try to help to make it work. I think EBV was put into place to save dollars so we'd have other monies to go. And, it was to collect information and get people paid at a quicker level, at a more accurate level. But is there still resistance? Is that why we have to put so much money into it through you, Madam Chair?
I'll tip it out, Representative Case, to DSS. There are some costs with implementation. And so therefore this provides us with the opportunity to fund them. We are not focused on savings. This is focused on investments. We know that our payment process can be cumbersome. It needs to be improved. These resources provide us with the opportunity to fund some of those improvements. DSS team, do you want to speak to the details of how we'd spend that, the 12 million from the EBV? That'd be great. Thank you.
Right. Thank you, Secretary McCaw, and thank you for the question, Representative Case. So I think that fundamentally from a federal level, for sure, EBV emerged more from a quality assurance lens than it did from a self-direction empowerment lens. Connecticut sees it as both. It's quality assurance, but also EBV is an absolute principal tool for people, employers, to be able to self-direct. So it's really both, not just about saving money. In order for people to be empowered as employers, which maximizes choice, autonomy, we know all those things already. And Connecticut has a long-standing, very strong self-direction program that emerged out of individuals with disabilities years ago who said they wanted to be the ones who would direct their own lives. And we honored that. EBV itself can be challenging for some individuals with disabilities to be able to use effectively in terms of making revisions to timesheets, for example. Let me give you some concrete examples, right? In order to make modifications, correct a timesheet, individuals really do need a PC. It's not just a smartphone. You actually need to have a PC to facilitate it. It's just more complicated on a phone. But if you add to that challenges with manual dexterity and then understand how challenging it could be, we just want to put in place the resources that really make EBV a useful tool for employers. There is some resistance. I'm not going to say there's not. It's small. It's more an understanding of how do we translate, how to use EBV to the now 22,000 workers in the self-directed system. Self-direction has grown exponentially. There are 22,000 workers across, in every small community. Every community has self-direction and workers who work in it. They speak more than 12 different languages, and they themselves have different learning styles and different experience with technology. It is a challenge to support that workforce in using EBV just because of the sheer numbers, the differences in language. It's not like an agency or a company that has an HR unit. It makes it a little bit easier there. So it's a little bit challenging. for DSS on the DSS's end, and I know DDS has rolled out and has a higher percentage of people using it. DDS does plan to have everybody using EVV. We also, however, have learned from other states that have put in place a long-term, more robust support to actually help employers make corrections within the system. We're taking that from the multiple states that have moved forward, that have all advised that there's an additional self-direction support. And so we're being proactive about that.
Dawn, if I can, Representative Case, if you'll indulge me 1 second. Dawn, I just want to clarify, EVV wasn't an option for the state. It's a federal mandate that we have an electronic visit and verification system. And its original purpose was to help identify fraud and abuse within the system. It wasn't designed or implemented to save money. It was to prevent us from wasting money. Is that correct?
There's definitely QA out of the federal government. It's a requirement.
And if I could just clarify for the record, the EVV investment is for the call center. It's a $2.1 million investment. It's a part of the category enhancing self-direction, which is a $12 million investment. But the EVV component on the call center is 2.1.
Okay. No, I thank you. I don't want to go drill down to that too much. I think, Representative Abercrombie and I will probably have some discussions because we started this 2 or 3 years ago, I believe, with Commissioner Bremby meeting in DSS's office. And, we were assured that, there would be different devices that somebody could use once they get into a rural area if it didn't have service, because so many people were worried about them using a person who needed care, their internet with a computer. People didn't want that. People didn't want them using their home phone and calling in. So there was going to be some other devices. And I think it sparked me up a little bit because it's 3 years later and we're still talking about it. And I personally would like to see, the process go, because we always talk about Allied and getting the payments out there to the providers in a timely manner. And I thought this was something that was going to be able to help get those payments out there, because it was going to be able to be reported at a much, I think most of the problems are the ones that aren't EVV, that are self-reported, that have difficulty getting translated to be paid. But we can have a discussion on that later on. Just to touch base, and not really questions. Secretary McCaw, I don't know, and I know you weren't around, and once again, Representative Abercrombie and I and others worked on the lien process. I really think it's important to always look at that document, because that document really pulls all the different agencies together. And it took a lot of time to do that with the previous administration. And that also gives you what Representative Porter was talking about, because it allows for that extra, I call it the extra touch or visit to somebody. It might not be by the agency that's reporting, but it's another agency who happened to stop in for a reason, but they can report on the BizNet system if we're still using that. And it was just a 1 week fruition thing with all nonprofits out there. And I really wish we would utilize that and try to streamline things as we are today. But thank you for all the information. And what everybody has come out of this is a lot of the nonprofits are just really unsure what the increases are and where they are. My interpretation is the first increases are the people who actually have the direct touch of a client out there. And it could be a van driver because they're helping them onto the van. It could be, so there needs to be, and I know Commissioner Sheff and I have talked about this in the past, an easy one-pager that helps these nonprofit agencies understand what and who gets the increases and where they are. So, and once again, Representative Porter said, these are the people who are on the front lines doing some of the work that nobody wants to do. Taking care of the IDD population. I mean, they should be getting the extra $300 a week because they deserve it. But we're not there. We want to make sure that our workforce and our most vulnerable are taken care of. And Representative Abercrombie, one question, and I'm done. So thank you very much.
Thank you, Representative Case. We'll do the follow-up on the lean work that you and Representative Abercrombie contributed to, and we'll work with our agencies to get some clarity on the increases across the spectrum. So thank you for that feedback. We appreciate that.
Thank you.
Thank you. Thank you, Representative Case. To follow up on what Representative Case was talking about, when we talk about EVV, correct me if I'm wrong, but the Commissioner Chef's agency is the only agency left to implement EVV. Is that correct?
Commissioner?
I'm sorry. We have implemented EVV and we are very near the federal compliance level with employees under our system. Krista, I don't know if you have anything to add to that.
Yeah, Commissioner, thank you. We are at this point, our interpretation is that we are in compliance with CMS's requirement on EVV utilization for our self-direction program. And from DDS's perspective, we also have EVV occurring with our private provider network for provider-based services. And my understanding at this point is that is also in compliance with the CMS requirement.
Deputy Commissioner Gilbert, I saw you shaking your head. Can you add to that?
Well, I just wanted to add to that in terms of, I would characterize the last phase of EVV implementation as being around the self-directed care area more broadly, which would include DDS and DSS self-directed care. So we are still working on coming into compliance with the federal standards on the DSS side for self-directed care. Part of the support that you see here is to assist us in achieving compliance through that the investment that's included within this plan around call center support in anticipation of a significant need for support of PCAs and clients as we move towards full compliance.
So are the PCAs, personal care assistants, the last group to be implemented into the EVV network?
Self-directed PCAs, yes.
And is that why the $2.1 million that's in this budget is to help with them being able to, one, call in when there's errors that are submitted by their employers for their pay? Is that where the 2.1 is going? And then the second piece of that is, who are you contracting with that's going to do the call center on that?
So we anticipate that the 2.1 million really consists of a significant footprint in year one in anticipation of the rollout of the EVV for self-directed care and the compliance issues around that. So there's a more intensive funding in the first year, and then there's lesser levels of funding to support ongoing operations of that call center, which we anticipate once we work through the compliance period, right, there'll be a lot less demand or need for the call center supports. And the current discussions are with United Way around the call center support. And Dawn, if there's anything that I missed or you'd like to add to that, please add.
No, it's United Way. It's exactly the two purposes that you suggested, Representative Abercrombie. It's to help employees, PCAs, make corrections. If, for example, they arrived and they had to do something really fast and they didn't check in for 15 minutes, or they forgot to check out, which can happen at the end of a shift, or for the employer to make approvals. We stood up, we aim to stand up this call center to actually support. Everyone knows we're looking at releasing a request for proposals for competitive solicitation for FIs. The call center is going to help us through the next year with both helping employers and employees, as I suggested, and helping us move towards a system where we actually pay from EVV, which we are not doing that in the self-directed system yet. So we need to move in that direction where we're actually paying from the EVV entries, not requiring PCAs to actually submit paper and also make an EVV sent. So right now we have a parallel system in place. We want to move to just paying off of EVV, but we need support at the call center to help employees and employers make electronic corrections quickly.
Yeah, and that's going to be a little complicated because of the fact that we already have a complicated system with Allied currently, who is the gatekeeper of this process. So I think that on behalf of my colleagues, we're going to need more information how you're going to link the 211 system to what Allied already has in place. And maybe what you're saying is with the new RFP, it will go under one new umbrella. I don't want to speak for you, but that's kind of what I think I'm hearing, which we all know we've had tremendous issues with Allied and the PCAs over, I will say, at least 5 to 10 years that I've been doing this work. So thank you for that. I really do appreciate it. Representative Aurora?
Thank you, Madam Chair, and thank you to Secretary McCaw and to Commissioner Chef and Commissioner Lambert and Deputy Commissioner Gilbert for the excellent update and presentation here. Really appreciate soliciting our input and providing us this information. As I look at this whole proposal, there's a couple of things which come to my mind looking at it as an overall basis, that it's really, it's strategic, but it's composed really of what I call running cost increases, in a sense that, we need to pay the caregivers more. And I don't think that's going to be for 2 or 3 years. I would expect that to be for a longer period, for forever in some sense, because that's what's required to attract and keep and retain good caregivers. And when I add up all the programs here, the 10 programs, the initiatives which are provided, I find that about $350 million are either directly rate increases or quality-based rate increases. In my mind, perhaps you can correct me, I'm just thinking it's $100 million a year cost of increasing what we are paying our caregivers. And while I do think that's strategic in some sense, but from my perspective, I also feel that that's something which is not really, that's an ongoing cost. And I would ask a question about, we would have to sustain it beyond that. And that kind of a running cost thought process or framework, I also include the assistive technologies, because I don't think that if this is successful, that you would say, well, but it's low touch technologies. And I understand, we do want to make sure that we do not take the personal touch away, because that's indeed very important. These low touch, even if it's low touch technology and tools, I don't think at the end of the year 3, we're going to say if it's successful, then let's just stop offering those or using them. And if we're spending $20 million a year, again, I feel that should be $20 million a year thereafter. These are new programs in that sense, or new costs, which are on a running basis. Really my question is, in terms of sustainability, do you also think that while these are being funded through the special ARPA funds, that we should, as legislators, think about an extra $100 million in those? Perhaps it's not going to be us in this specific legislator, but in future legislator, to be thinking about this extra cost of $150 million a year. So that's my first question in terms of sustainability of building this cost basis. And the second one would be specifically in terms of the strategic nature of the remaining, because I do see that the provider infrastructure is a strategic investment, and so is the workforce transformation, which I feel are extremely important. I actually think the strategic part is really fantastic. I think we need to invest in the caregivers' productivity, in their ability to do the job better. And since many of them are individuals or self-directed, as I hear, it's not that there is a HR department with training programs providing them. We are in some sense that entity. So my second question is, can you give some more input in that, or detail in that regard? Because what I've been hearing more is about payment supplement structures or billing structures investment, which is obviously important considering some of the complaints we heard during the session. But are there more clarity about training or providing them technology? Because I hear many challenges that caregivers really get hurt with weight, lifting someone, helping someone lift. and some very simple low touch technology tools like a vest or belts can help people really not get hurt. And that's a complaint I hear quite often from caregivers, how they get hurt on the job in that sense. So, so those two questions, and I've taken a lot of time here, if you would indulge me in.
Thank you very much, Representative Aurora. Your first question was with respect to the sustainability of these investments. What components of the plan will have recurring costs that the state needs to pick up? We were very cautious in trying to balance those items that would have a recurring cost. That's not to say that there weren't areas that we thought were critical to this plan that would have to have a cost that would need to eventually be absorbed by the state budget. They were not omitted, but we were also very cautious on looking at other means to pick those items that have been discussed for years that we could not fund that were more of a one-time nature. And so as you look at this $500 million investment, the items that must be picked up by the state, it's about 50 million gross. Majority of them are matched by federal funds. So the net cost to the state is about $25 million on an annualized basis. Now, some of the smart technology, they too are one-time costs. You're purchasing those devices, you're installing that equipment, it remains there. And so therefore, we won't be taking these tools away. We paid for them, we invested, we installed them, they stay with the consumer or the participant. Same thing on the environmental adaptations, right? They go in, they make the necessary modifications to the home, those investments are made, and these funds, will be used to serve X number of individuals in that capacity. So our exposure right now is about $25 million. A large part of that, and that's 25 million net, 50 million gross. A major component of that are the rate increases, because once they're provided, we're not taking them away. We're using that to enhance wages. The pieces that do go away on the rates are the temporary funds, those temporary stabilization funds. We're looking at that as a shot in the arm to help these providers based on what they've gone through over the past year and a half. They still will have additional costs pertaining to PPE and things of that nature, but also to stabilize the workforce in attracting workers, retention bonuses, maybe new hire bonuses to encourage them in the field, to come into the field and to stay in the field. We see that as a time limited need at this time. The rate increases on their salaries, their hourly rates should help bolster and make the field more attractive. Still more work to be done, to your point, and certainly to Madam Representative Porter's point as well. Now, with respect to the training, I will ask DSS to speak to what we are providing, or Commissioner Sheff, in terms of training supports for the workers.
So if I can, real quick, before I give this back to Dawn, an example of technology that I didn't provide earlier, but I hope I continue to illuminate how it is supplements services, doesn't replace services. But to your point specifically, Representative Aurora, on injury, there's now a device that allows someone to be repositioned during the overnight if they're bedridden and they can't move themselves. There's risks of blood collecting and clotting. Currently, we send a staff or two, depending on the person, in to reposition and rebolster that person during the night. There's now a bed that does that, which eliminates the need for a human lift and a human transfer, which further eliminates the risk of injury to the staff. And providers will tell you that workers' compensation, the state will tell you that workers' compensation is a fiscal burden that's challenging to manage when you're doing that human touch that requires lifting and transferring. So part of the money would be not just to provide the technology, but to train people to look for opportunities where technology can supplement and improve quality outcomes. And so it isn't all spent directly on technology, but for that purposes of training and the expertise that we don't have in the maturity of our growth in the assistive technology. And I think Dawn can talk a little bit more about that.
Sure, we saw exactly the same problem, Representative. Even if we did purchase assistive technology, the state has had assistive technology for years. It's not new as far as something that just happened. It's not. But there have been weaknesses in our ability to match the right equipment to the person, and then, to your point, to provide the needed ongoing training to make sure it's used. That has been a weakness. We all know this, I guess, buying the technology is almost the easy part. Making sure that it's integrated day to day in a way that's meaningful for the people that we serve and their providers or informal caregivers. That's been the more difficult challenge. And so for that reason, the plan does actually fund 5 full-time, regionally based subject matter experts in assistive technology to not only be present to make sure the right technology is selected, but then to support people and providers in the home. The idea is that if we can embed these skills with the providers, then moving forward, it will be self-sustaining in that our network will better understand how assistive technology can not just be selected, but also integrated meaningfully day to day in the plan. So very intentional investment in 5 regionally based full-time experts to try to make this happen.
Thank you. That's really helpful. When I meant that the assistive technologies are not gonna it's not a 3-year commitment. Although I do understand that those specific tools or technologies will stay in those homes. But I'm assuming that every year we get new clients or new customers, a new pool coming in. So I'm thinking that if these are successful, this element of spending $10 or $20 million, as you may say, has to be a recurring thing. And I'm a big believer in technology. I know we heard some other, and there are different points of view, but I'm a very big believer that this is the way to help our caregivers do their job. I'll just, and I really think that you have covered a lot of ground there. Just from my kind of a business background, I think about, strategic investments as a little different than raising rates. I know strategy can be used a little loosely based upon, in public sphere. But when I think about strategy and long-term investments, I don't think about, hey, we are increasing the rates. So when I see core strategic investments in the plan, I kind of see $100 million or maybe $150 million. And I think that's excellent too. I'm not going to sit here and say, well, maybe the other 350 is a loose strategic investment, but is in some way, a long required rate increase, and that's fine by me. But I just wanted to kind of point out that that's one framework where some people who are steeped in business background might see it that way. But also my constructive input would be that 150 million or 100 million, as I see in these real core strategic elements, which you pointed out, which are very strong, which are very required. I think we need to put more in there in terms of, we need more, because I think, just as I said, 25,000 caregivers, even if you provided, online before they started a 1-hour to-dos or what really happens, what are and you may be doing that, or the department agencies might be doing that, or some other training which is low touch but helpful, or some tools just like Commissioner Shep mentioned, which would make them aware that, hey, if you're always lifting someone and it's getting tough, make sure you ask for this tool or this technology so that you don't get injured, to improve the productivity of a workforce, whether in this context or in any other context. And myself as well, as member of the ranking of the labor committee, is an extremely important objective for us all across. And I commend you in investing on that, and I encourage you to do more. And that's my job, to always push a little more on the productivity side. You're doing on the rate side, but on the productivity side, on the help side, on the training side. And I that's a constructive input. Maybe there could be more in it. Thank you very much for indulging in me, and hope this helps.
Madam Secretary, we so appreciate you going over on time. We actually have 4 more questions. Is it okay with you to proceed, and then we will close out this hearing?
Absolutely.
Thank you, Madam. We so appreciate it. Representative McCarty.
Yes, thank you very much, Madam Chair, and I'll try to be very brief. First of all, just a very quick comment to all of the commissioners and the secretary. Really appreciate getting the information on this new reinvestment plan. I think it's going to be really very helpful to our home and community-based services. And I'm thrilled to see that the federal government is helping us to enhance the funding. So two very quick, when do you anticipate an approval of the plan from the federal side? And will there be an opportunity at all to, if there's something that they do not approve with the percentage of rates, will we have that opportunity to respond to them? That's number one. The second part is when I went over the home and healthcare priorities list looking in the past, I did notice that we do not have a Medicaid reimbursement rate, or we did not for some of our social workers that really do go into the homes and help provide the necessary services to help those individuals. And I'm wondering if there's been any movement in that regard, and does that fit in? I know today we're talking about waivers on the community-based services, but has there been any thought as to whether we can look in that direction? Because I do believe that the social workers can really help with the social determinants and seeing what is best for those individuals. And then I hope this is not more than two, but if we get more information on the pediatric complex services, I would appreciate it. Thank you. Thank you, Madam Chair.
Thank you, Representative McCarty. Ms. Lambert, would you like to take the plan approval question, and Deputy Commissioner Gilbert, the two rate questions, please?
We don't know the answer for sure about exactly when that's going to happen. We're hoping it's going to be any day. There are quite a few plans. I think Deputy Commissioner Gilbert might have the most recent tally that have been approved conditionally, which means that CMS is looking for a couple answers to a couple of questions. It looks like that's the direction that CMS is moving in, and that's actually what we're expecting is a conditional approval with a couple of questions on some outstanding kinds of matters that they just want more detail on. I mean, I certainly can guess, and rather than guessing, I'll just tell you what I hope. I hope that we hear within 3 weeks. That's what I hope. But we did submit, we asked for an extension, so we submitted a month late. So the states that have moved forward are those that submitted a little bit earlier. We're hoping any day, hoping within 3 weeks, and that's the best I can do. Not sure.
Thank you.
Thank you, Representative. So in terms of the rate increases, I just want to emphasize, right, that these rate increases are broad-based and across the board for both home health and waiver services. So we are covering home health services completely in addition to the waiver services. So it's a very broad base, and that would be related to the 4.5%, which consists of 3.5% baseline increase and then a 1% value add component. So that is across the board, as is the temporary stabilization payment, which is not a rate increase per se, but is a significant payment of 5% of annual expenditure levels, which will go to that same group across the board also. And the one piece that I don't think we've mentioned yet, perhaps I missed it, but we are also providing 6% minimum wage adjustment, primarily covered by what was already in the baseline appropriation. So there's another rate increase also being received for services that are particularly sort of minimum wage or lower wage level services, personal care, agency-based personal care assistants, companions, homemakers, home health aides. They will all be receiving a 6% minimum wage adjustment also for those service categories. And then to the issue of the pediatric complex care or pediatric skilled nursing, we are providing a total increase using some of the funds that were included in the baseline budget, but augmenting them significantly through this ARPA plan, a total increase of 31.7% for that service category. At approximate annual ongoing commitment of about $8 million to that area. So clearly, hearing the need for supports in that particular service category and hoping to have a real meaningful impact with that rate increase on service provision and provider supports.
Thank you very much, Deputy Commissioner. That does help clarify, but I'm still a little bit unsure about whether the social workers do qualify for Medicaid reimbursement for home health care visits. I think that's an area that we may want to continue to research. Thank you.
Representative McCarty, currently social workers are not getting reimbursed for that service. There have been conversations with DSS around this, and they are looking into it, but currently they are not getting reimbursed. Senator Austin.
Thank you.
Thank you very much. First, I want to correct the record a little bit on what was said. Madam Secretary, you said something about the governor putting in $10 million for mental health services, which didn't really talk about the skilled nursing capacity for adult mental health issues. The legislature felt that that wasn't quite enough, and so we ended up putting 25 million in each year, which you agreed with. And I think you agreed because you also agreed that the mental health services were changed. You know, we all were looking to deal with some issues relative to mental health on a greater basis than any of us had anticipated, in part because of the contract negotiations that you had with the IDDD community. I appreciate the work that you were doing, but I don't want to leave people with a misconception that the legislature shorted out mental health services. That's so far from the truth, and I know that that's not what you were meaning by what you said, but I want to make sure that people are recognizing the fact that the legislature put in an additional 25 million each year. The governor had put 10 million in for 1 year, and so I think that that's something that we had. I do have one question relative to the, and I just want to say the legislature and the governor both presented the budget, had it voted on, and all of us agreed to it. So, you know, if we could go back to everything that I would like in the budget and say that I had put in, we'd be here a long time. And so I just wanted to say that I appreciate the governor signing the budget, and I appreciate the work with you as we struggled with last minute negotiations. And so that all being said, part of this plan calls for a lot of consultants all over the place. And are we going to hire Connecticut-based consultants, or are we going to continue to hire people from out of state? Because I'd like to see our Connecticut-based consultants get some of those jobs. That might be a Claudio concern. Claudio, what do you think? How about some Connecticut-based workers?
We'll obviously work with Dawn on getting all that. There's actually very little that's by way of consultants here when the grand scheme of it, when you think of it as a $500 million investment, very small footprint in terms of total percentage actually goes to consultants. And one of them that we specifically call out is UConn, which is, you know, pride and joy of Connecticut, and certainly a major local entity that has provided resources in terms of quality management for the Money Follows the Person Steering Committee, and has helped with a lot of our rebalancing efforts, including some of the planning that predated even the current Money Follows the Person plan. So I certainly think UConn and other local consultants will be part of any outfit. And with that, you know, obviously we want to also get the absolute best people to inform this for our consumers.
Thank you, Claudio. And if I could just first picking up on the contracting and procurement question, Senator, we know that you feel very passionate, and we all feel very passionate that we want to have the most qualified consultants to work with, and certainly those from Connecticut. Obviously, you're familiar with that RFP process, and it is an objective process. It's scored based on skill set, experience, background, et cetera. And we hope that that process will yield some Connecticut participants. Can't guarantee that, but there's a very small spend in this plan on consultants. Your point is well taken, however. With respect to the record pertaining to mental health, there was nothing allocated in the ARPA plan for adult behavioral health. That was an area that we agreed That would be an area for follow-up. When we looked at the remainder of the plan, my comments were pertaining to the governor's specific proposals, and that discussion had not yet been completed, and we'd like to finish that discussion when we're talking about the balance of funds. So just to be very clear again, the ARPA allocation plan did not have the adult behavioral health. It was our intention to continue those discussions at the next opportunity. Thank you.
Senator Austin, are you all set, ma'am?
Yes, I am, Representative Abercrombie. I feel that we've both stated our opinions, and I don't want to get into the debate of last minute negotiations. Thank you.
Thank you, Senator. Representative Porter.
Thank you, Madam Chair, for the second time. And please forgive me and let me know if this has already been discussed, because I had to step away for a few minutes. But Madam Secretary, I just wanted to go back to the 95.4 million, the temporary workforce and provider stabilization funding. I have a request, if you don't mind, if you guys could provide the details of what the incentive-based program is that's going to help with the recruitment and retention of provider staff that's referenced on page 5. And if you could speak to if there are any incentives, for permanent funding to increase these rates and benefits for the staff. And if not, what are we doing to make sure that going forward, we'll be able to sustain what I feel is very necessary and needed, long overdue. Through you, Madam Chair.
Thank you, Representative Porter. So first, what we've heard very loud and clear from stakeholders, including union representatives, pertain to wages. So the minimum wage increase and the additional rate increases that are in this plan goes right towards your goal of what you're referencing is there an attractive wage for these essential services that the community is relying on? So I would say that the commitments that were made in this budget through the general fund, through ARPA, through the use of carry-forwards and surplus, while they don't get us all the way there, they are sizable and they're significant. And we should all be very proud of the amount of investment we're putting in the system. It's substantial. But obviously our job and our task doesn't end there. And I'm not sure if you were on when Commissioner Sheff and I responded to Senator Austin. She also raised a concern about as we bump up those at the minimum, does this create other compression issues? The worker who's been in a particular job class for 10 years might be making something very close to a new hire, and that might not help with retaining those individuals. So this is step one. Step one is to make these investments to adjust the floor, if you will. Step two will be to have the data in-house so we can look at individuals in specific job classes and years of service to see if there's a compression issue, and then begin to think about how we could address that. So to be continued, and we will certainly keep you abreast of the work that we're doing here and the administration. Now, with respect to the recruitment and retention bonuses, as Dawn indicated, our goal here is to create these operational planning teams to begin to put a little bit more details behind implementation. We have heard this from the community, again, with their difficulty hiring. They've been receptive to these ideas of recruitment bonuses or retention bonuses. And so obviously we still have to flesh out some of those details. Dawn, if you have anything that you could share with Representative Porter now, that certainly would be helpful.
Specifically about the work groups and the design sessions?
Representative Porter was inquiring a bit about the recruitment and retention enhancements that we have in the plan. Is there anything more specific that you have in terms of what will go out to the provider community?
So we have ideas. That's as specific as it is right now, and we want to generate ideas from them through the work groups. But what we'll do is probably convene the work groups with some initial ideas about what kinds of recruitment. But we want, they're the providers, they're the organizations. We certainly want them to take the lead. We just want to be able to provide the technical assistance and the funding that will allow them to put in place. And we also will be able to share best practices. We definitely want to do that. So we're not reinventing the wheel across all the provider networks, but we will do that through the work group structure. So yes, we have ideas on what a recruitment, a sign-on bonus might look like. We have ideas about retention and how that strategically might be done, but they're the agencies, they certainly want to hire staff as fast as we want them to hire staff. And we do want to be able to empower them with the funds and the ideas and technical assistance.
Thank you both for that response, Dawn and Madam Secretary. One question to you, Dawn, on what you just mentioned, the work group. Is this a work group that has already been formed? I'm definitely putting a plug in here.
Oh, okay. Well, you know, the meeting to try to figure out what the work group structures will be and put together our initial list, that's going to be, I think it's August 11th, September 11th. I would have to actually double check. It's yeah, it's the 10th. It's on the 10th. And certainly if you're putting in a plug for someone you know to be on that committee, we're happy to take ideas. It'll be diverse groups and make sure we have as many perspectives as possible.
All right. Thank you so much. I appreciate that. Thank you, Madam Chair.
Thank you. Senator Moore, followed by Senator Kushner, and then we will close out this informational forum. Thank you, Madam Secretary. Senator Moore.
Thank you, Representative Abercrombie. I just want to say these questions are really great. I don't sit on appropriations, so I have a question that someone might have responded to, but I've listened to everything. I didn't hear it. Will you be able to provide us in the way of funding what was ARPA and what was in the budget so we can distinguish where the funding came from?
Yes, Senator Moore, when you should have the PowerPoint, but I do believe we have a page in the appendix that at least when it comes to the provider rate increases, it shows the funding sources of how we braided the dollars together to implement those rate increases. If you're looking for something beyond rate increases, just let us know specifically what area of the budget you're looking for, or if you're looking for a summary of ARPA, a summary of carry forward, we can provide that at OFA. But when it comes to the provider rate increases, we included an exhibit so that we could track the three main funding sources that provided all that the rate increases across the provider spectrum.
Thank you. And then finally, you mentioned capital project fund. Is that correct? I heard you say that, Secretary.
Yes, yes.
What is that?
Okay, so the ARPA Capital Projects Fund was a separate allocation of funding that can be used for broadband and connectivity. We had some very brief discussion on this, Senator Moore, with respect to our bonding bond bill. And looking at items that would need to be funded through geo bonding versus was there an opportunity to use some of the ARPA capital project funds to support some of the areas that we had legislative interest in. So that funding source, there are areas that we have identified some allocations, mostly broadband connectivity related. At this point, the feds have not put out any guidance on how the funds can be used. So we are in a waiting mode at this point. And then we would be reconnecting with the legislature to talk about additional allocations from that funding source. So again, we have multiple ARPA supported funding initiatives. This was the HCBS. We spent a lot of time talking about the State Fiscal Relief Fund, which the legislature allocated in the budget in the implementer. And then there's also that separate capital projects fund, and we're still awaiting clarification from the feds on how the dollars specifically can be used, other than broad language on connectivity.
Thank you. I remember having the discussion. I wasn't sure if you had been approved or had we heard anything on it.
Not yet.
That I appreciate it. Thank you, Madam Chair.
Thank you.
Thank you, Senator. Senator Kushner.
Thank you, Madam Chair. I've been listening quietly to the discussion. I appreciate the questions of my colleagues and the answers that we've received from you, Senator, and Secretary McCaw, and all the commissioners. I heard that you are going to be sending us a list of the increases that are being proposed for the people working in this industries and their salaries. I think that we need to see both the salaries and the increases and see it very specifically. I know 6% sounds like a lot of money, but on a $15 an hour salary, that's 90 cents. And I am concerned that even though it sounds like a lot of money, it's not enough money for the work that we're asking people to do, and how, we have become so aware, as Representative Porter said, that these essential workers during COVID risk their lives, risk the lives of their families, and we have been underpaying them for a very long time. And so I appreciate the report. I look forward to that report because I think it will be revealing to us of how much more work we have to do, and that 6% may not be enough. Thank you.
Thank you, Senator.
So that concludes this informational forum. I want to just really take this opportunity to say thank you to you, Madam Secretary, to Commissioner Sheff, Commissioner Guilford, Deputy Commissioner Gilbert, and Dawn Lambert for being here today. I have to say that this is such an opportunity for us as a state to help people. We have done some really lean budgets through the years, and I'm just going to speak for myself. I've never been prouder of the work that we have done in this legislative session, and these dollars are going to go so far. I know there's a lot of hesitation with my colleagues as far as some of the language that's being used, what the rates are going to be. But at the end of the day, it's an increase that providers have been waiting for over 15 years. So let's rejoice that. And I really just want to thank you and the staff that's here today. This is a great opportunity for all of us. So with that, I will close out this informational forum, and thank you, everybody, and have a great day.
Thank you.
Thank you.
Thanks,